Hello, everyone, and welcome to our Pediatric Nephrology Fellowship webinar. Today, we have a great guest speaker. We have Professor Rupish Raina from USA, who's going to give us the updates of acute kidney injury and pediatric nephrology. We have very great panelists today. Professor Khalid Alhasan from Saudi Arabia. We have Dr. Azmeri Sultana from Bangladesh. And we have Dr. Shaegan, who is going to give us some samples from our pediatric nephrology fellowship. So great guest speaker today, Professor Rupish Raina again from Akron General Medical Center, Ohio, USA. And here is our brief agenda. I'm going to give you very small description of the structure of our fellowship. Then Dr. Shaegan is going to give samples of the materials of the fellowship. Then our guest speaker will have 25 minutes to present the up-to-date management of AKI in children. Then Professor Azmeri Sultana is going to moderate the discussion with Professor Khalid Al-Hassan, who's also going to give the closing remarks and the take-home messages. So our Pediatric Nephrology Fellowship is structured as 3 modules and 16 weeks each, and it's accredited by the American Association of Continuing Medical Education for 96 credit hours. It's online program, and we are proud to have MOU with the IBNA, the International Pediatric Nephrology Association, and the ESBN, the European Society of Pediatric Nephrology. Here is our great board with diversity from all over the world. We have Dr. Ali Lenuela from Pakistan, Dr. Elena from Amsterdam, Dr. Hanan Abdulaziz from Egypt, Dr. Jamila Qari, and Dr. Khalid Al-Hassan from Saudi Arabia, Dr. Niveen Soliman from Egypt, and Dr. Rasha Samir from Egypt, Dr. Roxana Shroff from UK, and she is the president-elect of the International Pediatric Nephrology Association. Again, we have also Professor Rupish Raina and Siddharth Kumar from India, Dr. Shaegan from South Africa, Dr. Vanderia from Brazil. Why did we choose the pediatric nephrology for 1 year intense training program? Because our children are very special to us. They are vulnerable, and sometimes when they have a kidney disease, their case is very complicated, and there is a lot of challenges. So also, if they are not treated precisely and accurately, they might have devastating long-term consequences. And there is also a huge management gap in the vast majority of these complicated cases, with no consistency or consensus in management of our pediatric nephrology patients. We really need to build up a panel of expertise, especially in the developing countries and the low-income countries. And we choose to have this program not based on a monologue or lectures, but on bi-directional education. So we love to have our all of our fellows engaged in the scientific materials, and we are going to train them how to do critical thinking and critical appraisal, and also how to best answer the challenging cases in their practice. So we adopted not to tell our fellows, not to teach them with a monologue, but to involve them in several clinical discussions and live cases, and also with MCQs and evaluation and assessment. All the materials are released through very smart platform. So all the materials will be released on Monday morning to all of our fellows, who are going to have username and password, so they can access the scientific materials, listen to the lecture, try to read the journal clubs, the state-of-art articles, try to go over the educational materials and navigate the scientific contents throughout the whole week. And because of our students are from 28 countries with different time zone, so we love to give them the freedom to have the whole week to navigate through the educational contents and to perform their tasks and assignments. So all activities are monitored through this smart platform, and every week we have quantitative and qualitative assessment to all of our fellows. So application deadline for the fellowship is day after tomorrow. If you haven't applied yet, please go ahead and do it. Acceptance of notification, the notification letters will be sent by next week. And we already created a WhatsApp group and email list to contact you. Our onboarding meeting for those who joined our fellowship will be on Sunday, January 26th, and the program starts on Monday, January 27th. So all of our fellows will get their platform credentials before that day. If you haven't applied yet, we are giving this temporary promo code for 10% discount that will expire in 2 days. So please take advantage if you haven't applied yet, and go ahead and apply before the deadline. We already offered several fellows from the low-income countries who cannot afford to join the fellowship. We offer them either complete tuition-free scholarship or 50% discount. And here is our syllabus and curriculum. As I mentioned, that the program is structured as 3 modules, 16 weeks each. So module 1 will be focusing on renal physiology and developmental nephrology. The first mini module of module 1 will be focusing on pathophysiology and physiology. Then we'll have another 4 weeks to focus on congenital and developmental nephrology and genetic kidney diseases. The last mini module of module 1 will be focusing on tubulopathies and metabolic disorders. Then the second mini module will be dedicated for primary and secondary glomerular disease and the vascular diseases as well. The last module will be dedicated for acute kidney injury, chronic kidney disease, dialysis, different dialysis modalities, and kidney transplantation. And by the end of the program, you should be an expert in the pediatric nephrology field, and you'll be graduating from a trainee or mentee level to a trainer and mentor level, and also you will receive American accredited graduation certificates. All of these activities, all of this knowledge has no value without changing our clinical practice and standard of care and improve our patient care, because the great aim of education is not the knowledge, but the action. And with that, I am going to stop by here and let Dr. Shaegan to give us some demonstration and show us some samples of our educational materials that he and 13 of other board members are going to teach throughout the whole 1-year online fellowship.
Thank you so much for that, Prof. Amr. It's great to see that we have so many people attending this, and hopefully I will not repeat too much of what Prof. Amr has said, but I will just recap a little bit. So my name is Shaegan Irusen. I'm a pediatric nephrologist. I'm also working in pediatric critical care, and I'm representing the Pediatric Nephrology Board. As part of this, I'm also enrolled in the Critical Care Nephrology Fellowship, so I can give you first-hand experience of what the training and the teaching has actually been like. So we do have our IPNA conference coming up. This is in Cape Town, in a beautiful, beautiful city, which is being held next month. And I do hope that we can afford to see a few of you there. It's always great to network with colleagues and form new professional relationships, just so we can interact with one another across the globe. So as said, the World Kidney Academy offers fantastic online fellowships that is afforded to all individuals across the planet, and there's a variety that can be chosen. And as said, they are asynchronous, so that people can join them and participate from wherever they are and wherever they live. So this Pediatric Nephrology Fellowship is kicking off, and we're looking at starting on the 27th of January. I'm very grateful that I've had the chance to network with some senior colleagues and colleagues who have attended many of their lectures. So you definitely have input and guidance from some senior leaders within the pediatric nephrology world. So as mentioned, we do have quite a diverse board representing multiple people from across the platform. This is a 96-hour accredited course, and importantly, and this is the part I wanted to talk about, there's 4 different modalities of teaching, and that is an hour lecture, or a minimum of an hour. There are journal clubs where all candidates will be provided with a journal to go through, and then there'll be specific questions related to that journal to just assess one comprehension and obviously revision of that material. There are also 10 MCQ questions, and whilst we have had a few questions of, will this be based on the lecture? Many of the time it isn't, but it's just used as another modality to teach with answers given to the candidates. And there will also be clinical case scenarios. So as mentioned, it is asynchronous. A lot of the lectures are recorded, but the important part is that all candidates will be part of a WhatsApp group at the very least, where all questions can be posed, so candidates can see questions from their colleagues, and you will also be able to interact with the module trainers who can give you first-hand experience of how to answer that question or how to tackle it from a different angle. And importantly, we do have memorandums of understanding with many organizations, and importantly with IPNA and the European Society. So this is something that is endorsed by other scientific associations, and I think that lends validity to what we're trying to do. So let's just look at, here's an example, and this was I was assisted with some of my colleagues to bring this up together. So this will be one of the multiple choice questions, and this will be from module 1, looking at ciliopathies and associated cystic diseases. And so the question is very simply, like an 8-year-old young girl presents with an acute kidney injury dysfunction. The medical history is of nystagmus at birth, hypertonia and developmental delay. The urine microscopy is relatively bland with no significant proteinuria. The ultrasound shows hypoechogenicity and loss of corticomedullary differentiation. So then as a candidate, you'll be posed this question and you get to choose. Obviously, if you've had a bit more experience within nephrology, it might be a bit easier. But whether you don't, there's still a learning opportunity here. So based over here, if we had it available, genetic testing is something that we would then employ in this patient. And if we look further, as soon as you have selected that answer, whether it's right or wrong, an explanation will come up and that will be available for the candidate. So with a brief explanation that genetic testing is a quick way to assess kidney insufficiency and will be beyond what a kidney biopsy is. Obviously, the medical history and that points to a specific syndromic diagnosis in this patient, but there is also, for example, in this example, a flow diagram that candidates can follow with references that are provided, so that candidates can look at those references in their own time to develop a deeper understanding of the various conditions. So the next part, and I do apologize, is this was supposed to be a audio played for everyone. This is a clip from one of the lectures that I prepared, but it's referencing this article, and I have put the reference up because we do have Prof. Rupish, Raina, who will be talking to us later, and it's an article that I've used in the lecture to give an approach to cystic diseases, and there'll be a full, this is one of the slides that I've taken out, and again, I do apologize that the audio isn't working well, but it'll just describe to candidates different approaches, how do you tackle these different conditions, what are associated syndromes, new management, to try and package everything for everyone to put together. So if we move on, so another article will be provided. This is where the main journal club will be. So it is a review article from the American Journal of Kidney Diseases. So candidates will have the time over their week to go through the article, read all the information, and then that will proceed to a question. So again, here we led with a caveat, not a caveat, sorry, a case vignette of a 5-year-old male patient reviewed in the kidney clinic, a history of polydipsia and very light urine. They're concerned about diabetes. The urine dipstick has no abnormality, and the ultrasound shows echogenic kidneys. So there's a question specific to nephronophthisis. We also touch on the associated syndromes with that, and this will test a candidate's comprehension of what they have to go through. And then again, with the direct explanation and references as well. And finally, I've taken this slide to actually show you what it'll look like. This is from the Critical Care Nephrology Fellowship. So the pediatric one will be very similar, but a case description will be given to you as a candidate so that you can see what is happening, to have an idea, to think through this relative to your clinical experience, or rather see how a case may present before you if you were to encounter a patient. Upon reading that, you will then be asked a question, and then when you have selected the case question, as in this one, the explanation will come up. If it was the incorrect answer, a red mark would come up, but it will still give you the explanation so you can learn further. And finally, there are discount codes available. So this is my specific discount code. It will offer 10% off on the course entirety. As Dr. Amr has said, we still are open for registration. So if anyone wants to take advantage of that, you still can. And I hope to see many of you on the fellowship and to discuss with you further. So thank you for your time.
Thank you, Dr. Shaegan, for a nice deliberation. Now, moving to this, our main topic is pediatric AKI. So, I'm so much glad and appreciate wholeheartedly to the organizer for giving me the opportunity. And the Professor Rupish Raina, who has been tremendously working for the pediatric AKI, the identifying risk factor. Then he has also been working for these preventive strategies as well. And he has been mentoring so many pediatric nephrologists from developing country or low resource setting country, including me. Professor Rupish Raina is Director of Research in the Department of Medicine, Akron General Medical Center, USA. He is both, surprisingly, he is both adult and pediatric kidney specialist at Akron Children's Hospital and Akron General Medical Center at Cleveland Clinic Foundation. He is also serving as a professor of NewMed Medical University and Case Western Reserve University, Cleveland. And he is the member for the ISN Pediatric Education Committee. He served as a National Kidney Foundation Advisory Board in Cave, Ohio. And he's one of the founder of the PCRRT Iconic. So, Prof. Rupesh, sir, it's over to you.
Thank you. Thanks a lot. Let me see if I can share my slide and let me know if it is visible to all of you. Can you all see my slides?
Yeah, Prof, it's visible.
Okay. So good morning. I don't know what a different time zone is. Let me talk about the pediatric AKI. It's kind of hard to summarize that in such a short time because of the amount of work is being done. So the way I structured it, more or less to go over the pediatric AKI basic part. So you look into the advances of the AKI. Initially, the pediatric AKI was not well defined because people thought these are the children's, there's no strict definition, and everybody was focused, being an adult and peds both, and everybody was focused on the adult ICU, more structured, more robust, more clinical trials were going on. But if you see the global incidence, 30 to 60% of ICU patients develop AKI in adult, and AKI affect around 25% of the critical ill pediatric patient, with mortality going almost equal to the adult, which are requiring the KRT. And for the purpose of the talk, KRT is a kidney replacement therapy. We have changed the terminology from renal replacement to the KRT. And if you see the mortality and morbidity, again, long-term risks are there. They have 4 times high risk mortality. And 15% of the ICU cases are actually needing some kind of KRT, and emerging data suggests that early KRT incision improve hemodynamic stability, but increases non-renal complication, and I'll come to that. There's a debate and timing of the modality, and conflicting evidence from the adult trials highlight no survival benefit for early KRT, but CRRT preferred in hemodynamic unstable, and intermittent hemodialysis is better solute clearance, but high risk for hemodynamic instability. So AKI, the new thing is evolving in the AKI is now subclinical AKI, which is under recognized. And some of the milder acute interstitial AKI may not be association with reduction of the GFR. Still, there is a risk. A lot of work is going on hyperfiltration and loss of the renal reserve, which is also coming along big time. Significant reduction in GFR from previously normal baseline may not cause creatinine to rise above the normal range, despite there is a loss of the nephron mass. Loss of muscle mass for critical illness and in chronic disease may be a confounding factor. The way I structured it, let's do a quick question so we can kind of in the pattern of these discussions. This is a 10-year-old child who comes to you in a PICU, and over past 24 hours, the child has developed oliguria, fluid overload. Lab shows creatinine of 0.3, sorry, 0.3, baseline is 0.6, BUN is 70, potassium 6, pH is 7.5. Bedside ultrasound shows normal kidney size and echogenicity. The child's blood pressure is low despite vasopressor, and the team is considering initiating the KRT. What is the most appropriate next step in managing the patient AKI? My favorite question I put on the boards in nephrology. Monitor urine output, delay KRT until creatinine rises, initiate ISD to improve solute clearance, initiate continuous renal replacement therapy due to hemodynamic instability, or administer diuretics to improve urine output. CRRT is what you have to do. There is no data, and I'll come to that data about using and making an oligoanuric to non-oliguric. Actually, there's more detrimental and more side effect than starting the CRRT, because you can manage the fluid overload, you can do a chemokine modulation, you can give any kind of TPN, and it helps in the hemodynamic stability. There is a global burden of AKI, and this is a nice summary from the WHO. As you can see, 8 to 30 million population having an AKI needing RRT, and hospitalized patient 5%, ICU more than 30%. It is real. AKI is real, not just the pathophysiology, but also if you look into the global burden. Let's do this one. 10-year-old boy admitted in the hospital, severe dehydration, blood pressure 85/50. He appeared lethargic, decreased urine output over 12 hours. Blood pressure test revealed elevated creatinine BUN. The patient is diagnosed with AKI. Which of the following statement regarding pediatric AKI is most accurate? And this is what the epidemiological question that you'll get in the boards. AKI requiring renal replacement therapy occur in 200 to 300 million children, and which is not wrong, which is not correct, because I told you that 80 to 30 per million population. Overall, 70% of the AKI cases in children are mild stage 1, which is not true either. If you see that around ICU patient, 30% of them, they need RRT. The incidence of AKI in critically ill patients is approximately 30%, and that's the correct answer. The mortality rate of AKI globally is 1.7 million per year, which is also not true, because the incidence, you can see mortality is annually 1.7 is not the correct. So this is how the development of the AKI is. This is a nice paper we published. You can go in 2010 and 11. People did not know the pediatric AKI coming around, referral criteria is coming around. We moved from there to developing Carpe Diem, NIDUS, then we developed P-rifle criteria, we did NINJA, we did KDICO AKI guideline. 2014 and 15, you can see a big rise. The PCRRT iconic came into the picture. Me and Khalid and Siddharth took over as the president, including Dr. Mignon McCullough. She's the director. She is our chief operating officer, or the CEO of our PCRRT iconic. And you can see now the guidelines are coming along, and more advances is going on in pediatric acute kidney injury. And this is just some of the papers that came out. Editorial, we had the whole supplement of advances PKI. This is our roadmap. We started in 2000, and now you are in 2022, 23. So much of things have changed. The groups are formed. The groups are formed from neonatal AKI. We are talking about long-term outcome. We are talking about the RRT outcome. We are talking about the quality improvement overall, and not we started doing the AI in AKI. This is not a simple road to move on. And I think what I personally felt that AKI with the PCRRT move up too, because taking some of our med peds, we took a lot of data in the adult and try to see if that fits in the phenotype of pediatric. This is my favorite slide. This is a paper came out in Nature in Pediatric Research. There is a very little time when you have a hemodynamic perturbation going from normal epithelium to damage, then it goes into the kidney failure. And I have added some of these new parameters or trials, which was not very significant. Phenoldiazepam, differpirone, anti-MHS analog, they were not very effective. The trials were done. And after the kidney failure, you have the sloughing of the cell membrane, the epithelial cells, and they combine with the Tom Horsford protein. And there were some studies which was done to use an apoptotic inhibitor, which is p53 IRNA, which did not show much effect. What are we now doing a trial in adult is we are trying to do a stem cell infusion cell between this place when you have a sloughing and ATN, then to have this proliferation, maybe we can help in early regeneration. This is my problem, because if you say right now, any one of us goes to in any part of the country and say, I have a chest pain, you're admitted. They'll do an workup for you to make sure that you do not have cardiac event. We do not have golden hours. Trauma patients have golden. Stroke has 3 hours. Acute MI 6. But sepsis-associated AKI, because most of the time it's hypodynamic, the effect of the GGT are different depending on the severity of inflammation and shock. What do we do once energy is established? We do not have the time between pre-renal going to the ATN, because kidneys are not like trauma patients, stroke, acute, and I forgot to add, now pneumonia, you need to get an antibiotic within 4 hours of ER admission. And this is nice paper, and I want all the fellows to read this. This came out in Pediatric Research, and we have shown what are the microvascular causes, what are the tubular causes, and this is how the phenotypes are. You have epigenetic modifications, and some people are susceptible to certain tubular injuries. Some of them did not do very well with certain sepsis. And this is a beautiful article for you to read about the advances in pediatric AKI. AKI is a syndrome. It is not just hemodynamic perturbation. Nice paper for Prasad, and we are working on some of these major apoptotic pathway. You can see that it activates the BAX BCL2 gene. P53 was considered to be the most detrimental for the oxidative stress, and that's why the trial was done. It was not effective. We are working now on caspase. Caspase 8 is the other one, which is coming out, and activated caspase 3. So this is a syndrome. It includes the cascade of chemokine burst. It is an inflammatory process. It is just not hemodynamic perturbation. And now we are talking about methods of attenuating or preventing sepsis-related kidney failure. It affects and other organs. It affects kidney, it affects heart, it affects the brain. And we are talking about attenuating by arginine, vasopressin, hydrocortisone, early resuscitation, maintenance of blood glucose, and activated protein C. Unfortunately, none of these have been shown very effective in the trials. Let's do this one. 15-year-old boy presents to the emergency department with a history of fever, lethargy, reduced urine output. On examination, blood pressure is 95/55. And let me know if I'm too fast, because I don't want to read and sit there to read all these questions. His capillary refill time is 4 seconds. He appears very drowsy. Blood tests reveal hyperglycemia, elevated lactate level, increased creatine 1.8. Which of the following intervention is most critical to prevent the progression of AKI? Isn't it the question everybody asks when you go around in the ICU? Administering a high dose of corticosteroid immediately without adrenal testing, initiate insulin therapy to maintain glucose less than 110, administering arginine, vasopressin if fluid resuscitation fail to restore blood pressure, starting early directed fluid resuscitation to improve perfusion, monitoring glucose level, and different treatment until hyperglycemia causes clinical system. Again, prevent pre-renal going to ATN. You have 8 hours window, and that is start early directed fluid resuscitation to improve perfusion. Now, this is what you have to do when you see a kidney patient with an AKI. Discontinue nephrotoxin, ensure volume status, consider functional hemodynamic monitoring, monitor serum creatine, avoid hyperglycemia. Now, avoid the radio contrast, consider invasive diagnostic workup, look for the causes. This is old. This was 10 years ago. Everybody used to write this: discontinue, ensure volume status, consider functioning, monitor serum. Here is the point. What I want to tell is role of a nephrologist. You have patients who are normal and have a high risk. Then you go to damage, decreased GFR, kidney failure. By the time you call me between the renal failure, next step is death. Can we do something for the early goal-directed therapy? Can we define blood pressure? Can we restore and optimize perfusion? Can we use inotropic care, mitigating the inflammatory injury and optimize RRT? What a good example of COVID-19, IL-2, chemokine burst. We have used Oxiris, and I've used in the children's too. And within 24 to 48 hours, we put them on Oxiris, we remove all the chemokines, the multi-system effect is getting better, and then we switch to CRRT. I didn't like to learn the mitigating inflammatory injury through the COVID, but that has shown that you have to mitigate the inflammatory injury. And I showed you in the diagram, it is not hemodynamic, it's caspase and other involvement. This is another from my paper from Nature is beautiful thing, increased risk. What are the exposures? What are the susceptibility? What are the markers for damage? What is the causes, the GFR, kidney failure, and death? I really like this table, and you should all have this in your pocket. You have P-rifle criteria, you have KDIGO, you have Akin, and PROC. You can use any of them, and beyond than that, I gave you mortality in the pediatric population with P-rifle stage 1, 2, 3, KDIGO stage 1, 2, 3, Akin stage 1, 2, 3. One thing I really, really want to highlight here, anybody with 3, I don't care what you use, P-rifle, KDIGO, Akin, the mortality likelihood ratio is almost 6 times. So this is a good table for you to carry if you want to talk to the family. This is what is happening in the systemic hemodynamic effect of cytokine, sympathetic nerve activity, RAS, vasopressin, thromboxane2, endothelin, leukotriene. Then you have a renal blood flow, and there's an intrarenal distribution of flow. This is a nice diagram for you to keep and see how the tubules are getting damaged. Did you see how much redistribution of low blood flow, and you have anaphylaxis, prostacyclin, calcium, PAF? It is a cascade of chemokine burst. This is a new thing that's coming up. And I kind of put it before that we are going to write this. And Khalid and Azmeri, we are working on to saying that, listen, we are missing overt AKI. I'm not focusing. I'm actually focusing on subclinical AKI, which is elevated biomarker, normal GFR. I'm working on hemodynamic AKI, negative biomarker, GFR reduction. You get tubular reduction damage, then you get overt AKI. If you have a subclinical GFR reduction, overt AKI. And our center is now looking to get the data to see what is the outcome of a subclinical AKI. Elevated biomarkers, normal GFR. What happened to the hemodynamic AKI, negative biomarker GFR reduction, and to see what this sustained damage or overt AKI. So whenever anybody tells AKI, I always say, is it renal or post-renal? Is it pre-renal, post-renal, or renal? If you're talking about it's a renal and damages there, tell me it's a subclinical AKI or it's a hemodynamic AKI. And then I ask them, is it an overt AKI or it is a GFR reduction versus tubular damage? This is something new data that came out in 2024. Now, what we are doing is we are calculating the city, which was estimated as neutrophil to monocyte lymphocyte ratio. And higher chances had a higher risk of AKI. Adjusted odd is around 3.95. And city is a pretty good indicator of AKI and fatality in pediatric ICU, and proposed normogram based on city yields an appropriate prediction value of critically sick patient. I love this paper. I'm writing an editorial, and it's done very well. And this is something now you have to grow out. And why are we doing neutrophil to monocyte ratio? We're talking about chemokine burst. We're talking about the whole cascade that AKI ensue. AKI classification, you have Riffle, Akin, KDIGO. Now neonatal is another coming on. There's some Japanese guidelines too, and you have mortality correlation. I think the first slide that I showed you, it's so good for you to keep in your pocket, which has all different kind of classification. Above and that, I gave you the mortality likelihood, which is going to help. I gave you what other things can happen between damage to GFR. And this is something what you'll talk about is fluid resuscitation, suspected to confirm AKI, fluid challenge, furosemide stress test, mental status, hemodynamic parameters, capillary refill, urine analysis, urine output. Or you are looking into the another pattern where you have fluid resuscitation, you have vasopressin, fluid challenge, furosemide stress test, and you're talking about the effect of these nephrology referral, look for ongoing volume need, risk for volume overload, avoidance of nephrotoxic drug. And this is something KDIGO, AKIN, and referral criteria, and this is proposed new definition of AKI that came out with 1S, 1A, 1B, 2A, 2B, 3A, 3B, and damage criteria. They have a biomarkers, and it is not possible. We don't have a point of care test right now to add, but this is a future where you talk about damage criteria as the biomarker and the functional criteria. This is definitely, I want you all to have the KDIGO criteria, stage 1, 2, 3, and you will have neonatal modified KDIGO. Now the new terminology is coming along. We thought AKI is going to cause some damage. So you have AKI, which is less than 7. If it is less than 3 months, you have a persistent AKI, then it is known as AKD, acute chronic disease. If it is more than 3 months, it is chronic kidney disease. And if you have no duration, right, and you have functional criteria, GFR more than 60, no decrease by 35% within 3 months, stable serum creatinine, no increase 50% within 3 months, or increase 0.3 milligram per deciliter within 2 days, no oliguria for 6 days, no marker of kidney damage, is called no kidney disease, implies no functional or structural criteria according to the definition of AKI, AKD, CKD. And I'm telling you why. When you have to get a baseline criteria and you do not have the numbers of creatinine, you look for this. And that's why I say baseline criteria is not for 1 year. I need it for 3 months. I need this definition. No decrease by 35% within 3 months. No increase by 50% within 3 months, or increase by 0.3 milligram per deciliter within 2 days. No oliguria for 6 hours. That is no kidney disease. Keep this definition very clearly if you're going to look for the long-term outcome. Is this classification real? It is. It is real. And this is a nice diagram I like, with acute kidney injury, acute chronic kidney disease, and then CKD, chronic kidney disease. Is you can see some of the biomarkers and how does the AKI stage 1, stage 2, 3 can space out to be acute kidney disease, acute chronic kidney disease, and chronic kidney disease. And this graph is very important, and they cross-talk with the different organs. And, you know, it is important because hospital stay increase with the severity ranging from 3.9 days stage 1 to 12 days in stage 3. Mortality risk also increases with the odd ratio 4 for stage 1A, 10 for stage 1B, 41 for stage 2, 60 for stage 3. So this is real. This is real. This is our paper came out in JAMA, is the summary of variable across 49 patients in acute care in kidney injury. See how much a load, economic burden we have in children's in the AKI, and we use the FIS database. CHMI, that is the Children's Medical Hospital case mix, major complication of comorbidity, how much it is causing an economical burden, and there is a correlation of variables with mortality rates and the length of the stay. And another came out on the cost and outcome with pediatric research in Nature, where it shows mechanical ventilation, died during hospitalization, duration of stay, total charges. AKI is causing a lot of economic burden for children, and you can see the collaboration of plot of the best fit multivariate logistic regression. Evaluation, you have to do the urea creatinine electrolyte, definitely you have to do chest X-ray ultrasound, smear for HUS, definitely if you're looking for GN, you need to do C3 ANA ANCA. This is my favorite slide of diagnostic features. Oliguria, non-oliguria is 29%, serum sodium, urine sediments, whether oliguric versus non-oliguric, the percentage. And now we have a scoring system based on the granular cast and renal tubular epithelial cells. And this is renal tubular epithelial cells per HP fields. You can see 0, 0, 1 to 5, 1 greater than 6, 2. See if you have renal tubular epithelial cells more than 6 and you have granular cast more than 6, that the grading is around 4. And these are some of the tests that I want to put you in to say that this is 17-year-old male man comes to you with BU and creatinine. What do you see here? You are seeing, and this is This is actually a muddy brown cast, and you can see the renal tubular epithelial cells. You all need to evaluate your own, have your own microscope and see these two. I don't round until I run the sediments and look at it. Moratian, you can see some broadcast dilated damaged tubular cells. Now, understanding subclinical AKI and renal angina, we want to have a renal damage. Before than that, we want to assess the subclinical. Renal function is about up to 50% mass compromise before creatinine rises. And renal angina is a composite framework of symptom, signs, and biomarker and a prognostic marker. And you can see the cardiorenal parallelism, creatine positive and non-creatine positive AKI. And we are talking about now, as exactly so it's functional versus tubular. Role of biomarker, because broader AKI diagnosis to include early subclinical stage needs to be identified. And this is what we think. We need to see what are the biomarkers? Can the subtle AKI can be assessed? Can you work on hemodynamic perturbation? Can we halt this process before the chemokine burst? And this is what the postulate, the direction AKI is moving. This is our paper, came out in Pediatric Nephrology, and this is what we did as a label box. This is I learned from the AI, which is new thing. And we found out that there are certain, these are some of the biomarkers, and this is how we started the biomarker history. This is a funnel. You come down, put all these biomarkers, beautiful picture from a paper in Nature. You can see all these tubular markers. They come out, they filter, and then I have put you the value of these markers to see how you can predict AKI. This is beautiful outcome of the biomarker clinical study. Urinary NGAL. Elevated level detect as early as 3 hours after renal injury. Performance varies with the context. FDA approved in 2024. And then you have a TIMP and IGFBP, which is actually the nephrocheck, and that's predict the progression of AKI. And you can see the response with and without, with urinary being positive, without having the area under the curve was around 0.9. And this is what you're looking for, because TIMP and IGAF actually is the interface between the G1 to DNA synthesis to G2. Again, biomarkers are good. You can see that. You can scratch your head with 200 biomarkers, but at the end, 2 are up and running is NGAL and nephrocheck, which is at TIMP, IGFBP. And I think what they call as Topaz is the study which they did is the urinary TIMP and IGFBP is very strong because it tells you the damage going through the G1, G2, and DNA phase. This is a paper came out in Pediatric Nephrology. We have developed the STAR score where we look into the sensitivity, specificity. We have a study design. We look into the 10 markers for the stars. And then you can see the analysis. This is what we are proposing now for the neonatal AKI. If in NICU admission, you have star positive, limit nephrotoxic, avoid contrast, check inflammatory status, hemodynamic support, AKI biomarker you add. If it is positive, then substitute avoidable nephrotoxin, avoid fluid overload, consider RRT. If negative biomarker, conservative fluid management, adjust nephrotoxin. This is how the days are. This is how our AI, neonatal AKI is moving in the direction. Fluid core for resuscitation, we have FEAST trial, surviving sepsis guidelines, SAM guideline. I put it all for you. Key finding is bolus increased 48 hours. Mortality, no difference between saline and albumin, FEAST trial. No bolus had better survival outcome. Reassess fluid strategy in low resource setting. Surviving sepsis guideline. Early fluid resuscitation improve outcome when guided by frequent assessment, use of norepinephrine for MAP less than 65, emphasis on timely fluid therapy, reassess and advanced monitoring in resource-rich country. SAM guideline, aggressive fluid contraindicated, careful correction of electrolyte, and avoid fluid overload, emphasize tailored rehydration stage for the SAM. Children, they were having a severe acute malnutrition and they use Resolve Mal or cautious IV fluid 15 ml per kilogram per hour. And summary of early goal-directed therapy for septic, key finding from RICE, process, and promise. You have to have current CVP 8 to 12, mean arterial more than 65, urine output 0.05 ml per kilogram per hour. I always look into SCV2. SCVO2 should be more than 70. then what they look is there's no difference in mortality at 1 year follow-up, no survival benefit between early goal-directed therapy and usual care. Meta-analysis finding combined the data of ERISE, process, and PROMIS-CRAL, overall odds ratio of 1, indicate no significant difference in mortality between early goal therapy or standard care. Early goal therapy do not improve survival over usual care when applied broad in a resource-rich setting, highlight the importance of tailored patient-specific nutrition status and IV fluid. And that is what is more important. Risk of excessive chloride is there. You get metabolic acidosis, mortality, highly associated rate in critical care. You cause reduced perfusion, vasoconstriction of renal artery, decreased transglomerular pressure, dilation, coagulopathy, you get fluid overload. And this is my beautiful slide. You should keep it in your pocket. How much osmolarity, how much sodium, how much bicarbonate you have in 0.9, Hartmann, Ringal lactate, Ringal acetate, plasmalite A, and you have the Ringal funds. And if you're rounding with me, I am going to ask you how much acetate is there in Ringal acetate. I'll ask you how much is the ratio of sodium to chloride. You used to use a balanced solution like Hartmann or Ringal lactate or plasmalite for fluid resuscitation to reduce complication associated with normal saline. And this is what the guideline is. Key recommendation is crystallize is the first choice for volume replacement, surviving sepsis guideline. You can see that albumin considered in addition to crystallize if large volumes are required. Weak recommendation, low quality evidence, and systematic review is done around for 10 studies, starch versus crystallite. Increased risk of RRT is starch use, and it's basically an intensive care. KDIGO guidelines says avoid the HES, which is hydroxylide starches due to increased risk of renal dysfunction. Use isotonic crystallite, the preferred fluid for volume expansion. So this is takeaways, use crystallite for initial resuscitation, add albumin selectively in patient using sustained fluid volume, avoid starches due to association of increased need of the RRT. And this is a pendulum you have to deal with, fluid versus excessive fluid. Fluid overload is a real ICD code in sepsis AKI. This is our paper, and you can see you can calculate on 24 to 48 hours, and you can see fluid overload is bad. It causes so much of endothelial shear. It causes renal plasma, decreases the plasma flow, reduces GFR. It is causing delirium, decreased oxygenation, pleural effusion, myocardial contractility goes down. And then we have associated with AKI, in the fluid overload and renal angina index to predict more higher subclinical AKI. And the renal angina score is compared, and you have very high score 1, highest 2, moderate. These are the things you have to look for. Scores are 5, 3, 1, and higher the RAI, the more need of RRT. And this is what we have just come out with, even in children's paper came out in JAMA, that is fluid going associated with the respiratory outcome in extremely premature baby. In the secondary analysis of placebo-controlled randomized control trial in 874 premature neonate, fluid balance during the first 2 postnatal week was associated with mechanical ventilation and bronchopulmonary dysplasia. The time to return to birth weight was shorter in neonate who continued to receive mechanical ventilation, and every 5% increase in the fluid balance was associated with increase in order of mechanical ventilation. This is a very good paper on POCUS. Now, what we are doing is we are doing this study where we have VAX's ultrasound score looking into the IVC, hepatic vein Doppler, portal vein Doppler, renal vein Doppler. You can assess the fluid overload on that basis. This is my favorite slide from Dr. Mehta's paper, is this is what you're doing with machine and this is patient. You want to make sure that what is needed should be balancing out between patient's need and the machine. You don't want machine to be sucked in with the patient still staying what they are. So it's known as precision of fluid overload. Fluid regulation, you need to look for ultrafiltration, replacement, CRRT fluid balance, and patient balance. Key point, fluid therapy is integral. A threshold may exist beyond which perceived benefit of additional fluid therapy after resuscitation may control harm, prevention of fluid overload. And now we are looking into genetic polymorphism. These are some of the genes have been identified. And some of these people, they have these genes and maybe they are more proposed to these kind of thing. And then there's a furosemide stress test where you have to give it's basically on a thick ascending loop of Henle. Furosemide is highly protein wide, not filtered through glomeruli. This is how the dosing is, and you have to look for urine output. Let's do this question. 7-year-old boy, PICU, severe dehydration comes to you. Which among the following outcome during furosemide stress test is more predictive of progressive AKI? Answer is B, less than 0.5 within 2 hours. And this is how the FST is important. This is just an algorithm from one of the website. You can go into it and see how does the FST helps. And again, be careful. It is a furosemide stress test, but don't convert oligoanuric to anuric, anuric to oligoanuric to non-oliguric because they have more effect. This is my favorite slide, just to give you a full set of observation and look for hypovolemia and fluid overload, and when to consult cardiology, when to give the fluid overload, and what is the role of FST and loop diuretics. This is another 7-year-old boy, septic shock, AKI, admitted to PICU. He's oliguric. Despite fluid resuscitation, his weight was increased by 5% due to fluid overload. Which among the following statement about use of diuretic, this is most consistent with the trial data? FST, improved long-term kidney recovery in pediatric AKI, fluid overload more than 10 is an independent risk factors. Diuretic reduces the need of renal replacement therapy. Furosemide is contraindicated in all cases of oliguric AKI. No trial has evaluated the role of diuretic management in fluid in pediatric AKI. Fluid overload more than 10%, 10% is a risk factors for poor outcome, and diuretic can reduce. The fluid balance is a AWARE trial. No loop diuretics for preventing treating AKI because basically it affects more worse than anything. And rational use of diuretic in neonatal intensive care. A quality improvement study has been done with a baby ninja where we are identifying the AKI and fluid overload. Now, in absence of hemorrhagic shock, we suggest isotonic crystallite, then Khalid as initial management of expansion of intravascular volume in patient at AKI or with AKI. And these are some of the pitfalls that we talked about. Yes, there's no consensus, but yes, hydrocortisone and septic shock only for children with catecholamine resistant and suspected proved adrenal insufficiency. And these are some of the trials which I talked to you in my initial slide. Nothing is working. Dopamine, IGF-1, anatride, RANP, fendolipam, and some of these trials were done, some of them were prematurely terminated. And we always talk about which pressor should we give. Septic shock is a prototype of high output, low resistant. In setting of vasomotor paralysis, preservation and renal perfusion is important. Vasopressin is gaining a popularity, and because this is how it helps, it causes mesenteric vasoconstriction, decreased cardiac output, significant decreased urine output, significant increase in creatinine clearance. This is a vasopressin trial. I'm not going to go into it, but we'll suggest a hemodynamic monitoring. Physiological goal are to return the mean arterial pressure more than 65, CVP 8 to 12, improve blood lactate level, SCVO2 more than 70, urine output 0.5 ml per kilogram per hour. These are some of the guidelines. And adenosine receptor antagonist, yes, we suggest that a single dose of theophylline may be given in a neonate with severe perinatal asphyxia who are at a high risk. And this is how does it have renal benefit, renal perfusion by modulating hemodynamic parameter, reduction in biomarkers of acute kidney injury. And this is caffeine versus theophylline. Some of them they have used. Theophylline causes renal vasodilatation, caffeine more neuroprotective and renal perfusion improvement. And you can see the reduction that's around 50%, in theophylline around 60%. And you can see the narrow therapeutic window in the setting of theophylline. And which UA is most consistent with contrast-induced ATN? My favorite board question I always put, this is what you get. You act as a pre-renal, but you are ATN because dilute urine failed to concentrate the urine, no RBCs. And this is how the contrast-induced nephropathy is. What we do is we always prevent by using normal saline 6 to 12 hours before, 5 to 6 hours after. There is nothing which is proven to be good. And you calculate it. This is CNI is not a big deal anymore. I'm very much trained to give bicarbonate, but you can always use saline or bicarbonate, 1 ml per kilogram per hour for 6 to 2 hours before, and then 6 to 12 hours after contrast. And these are the CNI risk stratification based on the GFR, what you should do. And if you have 30 to 50, use low osmolar or isoosmolar, and implementation of pre and post hydration. And diuretics has no benefit. You cannot convert non-oliguric or oligoanuric anuric to non-oliguric. The data didn't show the mortality more worse. Let's do this case, 6-year-old girl admitted in PICU, and she's on a continuous CRRT, nutrition assistant relief hyperlipidemia. What do you want to do? Nutrition is a big issue in AKI CRRT. The answer is you keep protein 1.5 to 2 grams per kilogram per day. This is our paper came out, and this is a nice AI strategy. We know only 42% of the intensives in PICU are paying attention to the nutrition in the CRRT, and these are 2 guidelines. I'll highly recommend you to read our guidelines in nutrition and Kidney 360 as our executive summary. It is so important. Khalid is here. He's one of the part of our consortium. You need to focus on nutrition. Now nutrition is changing to different. Now AKI is defined in 2 ways: hypercatabolic AKI or normal catabolic AKI. And this is another outcome we are looking, and you have to see how to calculate the urea nitrogen balance. And we are going to look at an outcome between hypercatabolic and normal catabolic AKI. Wait for our data and paper. It's coming out good. This is our nutrition guideline. Avoid restricting protein to delay RRT. Suggest administering protein on dialysis, without dialysis. Nutrition. These are the markers from our paper, what you look for the AKI. Nephrotoxic ninja definition, you need to be careful for all the antibiotics. AKI rate doubles with 3 nephrotoxic agents. Incidence 19 to 30 with aminoglycoside. Nice slide for you. These are list of the nephrotoxic medication. You need to be careful. Medication counted for 7 days after administration towards exposure due to their long half-life. All other listed medication count for 48 hours after the exposure. Management of complication, definitely fluid overload, pulmonary edema, hypertension, metabolic acidosis, hyperkalemia, hyponatremia, but we are changing. This is a paper I thought I'll do it before my retirement. I did it in a mid-career. Change the terminology of renal replacement to renal support. You need fluid overload. You need to manage TPN. You need to do chemokine modifications. No more renal replacement. It's renal support. And you can do this in a life-threatening condition, but I want renal support other organ based on individual need. Indication should be broad, target for overall support renal and non-renal indication. Long-term paper that came out in pediatric AKI associated with increased health service utilization post-hospital discharge, done by David Ashkenazi group, but we have already published more from JAMA and Nature showing it's more words in AKI. There is a CRRT advances. There's no benefit. If you have CRRT, IHD, PD, do what you know. Do what you're good at. It doesn't matter. But for anticoagulation, CRRT, we're pushing for citrate. And also close collaboration between nephrology, ICU, nutritionist, and the ID you need, because it is a combined effect. And close collaboration can help you a lot. This is my very, very good slide when you do CRRT. What is prescribed? What is delivered, what is the ratio of delivered to the prescribed dose, timing between CRRT exchange, effective CRRT treatment, vascular access, mortality, what is needed. We need a new criteria for adequacy of treatment, were implemented in the clinical routine, avoiding underdosing of the treatment and favoring the achievement of therapy. Targets such as fluid balance, control, restoration, homeostasis, correction of biochemical derangement, and excellent blood purification, therefore making CRRT a well-established form of therapy. This is real. I'm sure most of you have dealt with these kind of changes in your practice. AKI is real. Remove the terminology from renal replacement to renal support. Talk about early goal-directed therapy. Look into SCVO2. You cannot get out of these parameters. I will come sometime where I will have what we call is a kidney pain, and then you act on it before going from pre-renal to ATN. As I showed you, it's a chemokine burst. It mitigates the caspase, all these chemokine phenomena, and I don't have much time. Maybe down the road, I'll do a whole lecture on advances of CRRT. COVID taught us the response of COVID, the chemokine burst. So with that, I want to end my talk. And I try to put whatever the new advances are. I don't want to do a basic talk for you because we want to do that. You get more knowledge. AKI is evolving. and soon we'll get more response. At the end, I want to thank the organizer for especially Dr. Jamila Curry. She has asked me to do the talk in AKI. Thank you for Dr. Khalid Alhasan and Azmeri, Dr. Sultana to be here, to be in the panel. With this, I will open the forum for the question.
Thank you, Prof. Pediatric AKI is a huge term and huge topic, but you covered it so well. You start from the diagnosis, risk factor stratification, then prevention, treatment, so on. So the problem is basically the diagnosis of pediatric AKI is a little bit tricky for developing country as well, because we don't have that baseline creatinine. And you have also shown the slide that newer definition of diagnosis of AKI, which is new to us. So Prof, could you please enlighten more, because my fellow and me all are here and they want to know how we can diagnose the AKI, where the every diagnostic criteria has shortcomings. So
Right.
Yeah.
That's a good question. I generally use the Akin criteria, which is a good one. And I can tell you one thing in pediatrics, urine output is a very good surrogate marker for your AKI because it all depends on your solute clearance. Unfortunately, by the time the creatine comes in, I showed you in my diagram, it's renal failure and death. The mortality is 70%. I think what we want, which is going to be difficult in US, and I don't know how that's going to happen, in the other part of the world, is to look into the subclinical AKI where GFR is not going, but you have a loss of the nephron mass. You have tubular damage. I showed you the nephrocheck, which looks into the DNA synthesis of that damage. Maybe those are the things can help. But again, it is just easy to say, hard to do. But fluid overload is a real ICD definition. Urine output, look into the malnutrition, look into not the creatine, but other like hypoalbuminemia, worsening fluid overload, looking into the urine sediments. These fellows nowadays have grown and got too much smart and don't want to look at the urine. I do not make the diagnosis of ATN unless I spin the urine and look into the urine microscope. You'll be surprised. You'll see so many things in that. Good example, yesterday I was seeing a patient who is has a blood in the urine, and I was looking into it. They're loaded RBCs. None of them have bleb, and then we figured it out. It was hemorrhagic cystitis as a bone marrow transplant, and finally we figured it out. BK is positive. So again, going back to old school, there's no way you can just put the magic wand and say AKI versus no AKI. You need to just work on the subclinical AKI, which is more important. My first slide where I showed you the classification, I have you all the three classification. That's the people, they make a like a small printout and they keep it in the bag. And I told you the mortality with anything you do with stage 3 is almost more than 6 times.
Right. So, Prof, there is some question in question answer box. I guess it is the Prof Rupish already answered about the hydrocortisone in septic shock, where there is renal adrenal insufficiency is proven. And I don't know his question, lactate in sepsis, maybe he was trying to say that the fluid resuscitation in critically sick children, where we are using balanced solution, so there is a lactate, Ringer's lactate. So he was just asking in sepsis whether we using lactate based crystallized solution or not.
Lactic acidosis has nothing to do with renal lactate. It has
Yeah.
acidity. If liver is doing well, it will convert. And it's an early goal-directed therapy. You need to more have a hypertonic, not just an isotonic or a hypotonic for intravascular volume to mobilize it. You can use, the only problem with normal saline is we overdo it and we get hyperchloremic and it has more disastrous effect. I showed you in the trials. So I generally like ringal lactate, and actually in adults, we have changed our practice. We only do until there's a hyperkalemia, they do well with the ringal lactate. But lactic acidosis has nothing to do with ringal lactate, but lactic acidosis is a good marker as SCBO2 more than 70% to tell you there is a peripheral the vasoconstriction there or not. So lactic acidosis being high will just tell you that you're not perfusing it well. But you have to be careful. There is no gut ischemia. There is no other abscess. There are no intra-abdominal process going on. And I had a case, patient came to us on CRRT, the lactic acidosis was 20. And they came to me and they said the clearance is not good. So I went to high flow, 24, regenerating. I said, listen, somebody has to do something for the belly. And then we did the scan. There was complete mesenteric necrotic bowel sitting there. Don't underestimate lactic acidosis, a good litmus test for lack of perfusion. That answers the question.
So another question from Sanaullah. In the pediatric patient diagnosed with AKI according to KDIGO criteria, presenting with oliguria or anuria, significant fluid overload and normotension, would CRRT be preferred? Which CRRT be preferred over diuretic? Would CRRT be preferred over diuretics as the initial management strategy? Could you clarify the indication of CRRT in such scenario?
So nice to hear from you, Dr. Hussein. My answer is do the FST first. Furosemide stress test. If they respond, then it's fine. You have a renal reserve. Now, if you're doing the CRRT, you have to have your goal very clear. What are you looking for? Are you working on fluid overload? Are you working because you need some TPN and nutrition? Are you looking to mitigate the chemokine? Are you looking to just make sure that down the road the patient will be oligoanuric? So you need to, it's a very patient-dependent phenotype, but you need to define your goal. If it's oliguria, anuria with significant fluid overload, more than 10%, try to see if the FST, furosemide stress test, work or not. If not, more than 10, mortality in 20% is pretty high. I will start CRRT. A good example is the veno-occlusive disease in bone marrow transplant. We have a guideline came out from our group, Azmeri was in that too, is anybody 10% not responding to diuretic, we put them on CRRT. So your goal needs to be very clear. There is no magic one I can say. Could you, yeah, and you said that actually, could you clarify the indication? Indications are fluid response, fluid overload, no responding to the diuretics, exogenous need of the fluid, oligonuria, marked acidosis, ventilation going into the ARDS. These are the things, severe sepsis, ongoing ischemia, not responding to the early goal therapy is other indications of CRRT.
Then another question from Izam that to adjust medication in AKI, what is the best way the formula to calculate GFR non-stable creatinine?
So I can tell you very well in the CRRT, if you are using the total fluid replacement is 25 ml per kilogram, 25 to 30 ml per kilogram per hour. eGFR 30 is the dosing. Although sometimes people also do the measurement. Now, the children's dose, the calculation for the AKI on the dose is some of them are dependent on the values on their serum level. Otherwise, you always use the CK Cockcroft MDRD calculation. Mainly in the adolescents, in the young kid, you can use the Schwartz formula.
Prof, is there any role of the median age-based eGFR formula normodative value who doesn't have the baseline creatinine at all? Then we can just take the retrospectively the median normodative data that is.
I'll generally take the peak one. And then on the basis of the peak one, you just adjust the medication because you are going to make sure you're not messing it up too.
Okay, Prof. Then so many questions, Prof, now.
Yeah, I can read it. Can urine creatinine measurement help in predicting renal recovery in AKI? Okay, for that, Dr. Alhasan is there. He will give you an answer. We are working on the termination of the CRRT. So wait for the data. It's coming out very soon. Among all these criteria, AKI, RIFL, ECK, KDIGO, which one should be used preferable? Does it make any difference in clinical outcome and which one to use for the standardized of the research? So I gave you my chart. It was very clear. All of them, they do well in stage 3. All of them, they do well in stage 2. Do whatever you like to. If you like, I use ECK. And most of the data, and if you see the research studies, they are done on ECK. Now, I also showed you the classification. Now we are actually looking into the AKI staging with the biomarkers. So that may be the very good thing for the research. But ECK is very good. KDIGO is mainly done in the adults. So I don't know about the pediatric KDIGO. I'm not very excited about it, but P-rifle and ECK is the one which you can use. And ECK, if you see the staging, is very well predicted with the mortality. And so that's a good one.
And then, it doesn't need baseline creatinine as well.
Right. Would you recommend screening for prematurely born baby with very low birth baby for neonatal AKI? Good question. Yes, you should. You should be watching it. There's no creatinine that I can identify. Watch for the urine output, fluid overload. Very good. Very good question. Then is And by the way, we are working on the new STARS modification now for looking into the low birth weight baby AKI stratification less than 1500. It is written that we should not label it a pre-renal AKI if the kidney, sorry. It is written that we should not label as a pre-renal AKI if the kidney functions improve after fluid resuscitation in less than 2 days. Your expert comments, less than 6 hours, you should see the perfusion. And I gave you the criteria, the CVP, SCBO2, MAP. Those are the criteria. They are getting better. It's pre-renal. And you don't wait for 2 days to get better. After 6 to 8 hours, if you don't respond, did you see my diagrams? You're going into the ATN phase. That hemodynamic perturbation doesn't work. Pre-renal to renal, pre-renal AKI is when you find volume deficit and all those criteria that I put it in. And you're right, after 2 days, I don't call that. I have a question about type 1 hepatorenal syndrome. What is more appropriate to start, KRT or telepressin, albumin, or Acute? So basically, hepatorenal syndrome is not defined well in children. We have no criteria. You're using the data from the adult. And HRS1 generally respond very well with the fluid, albumin, telepressin, unless you go to HRS2 or you have hyperammonia. And that's another guideline we had with Dr. Sultana and Dr. Khalid Alhasan. We can share that came out in actually main Nature Journal. So most of the time, HRS1, they respond. And we go, it's just, I think I'm just, among all the criteria, okay, please, I have a question. It says when AKI include I have a question. Assessment of GFR in AKI include GRR or actual GFR according to the surface area of the patient. I generally use the in the adolescent, I use CKD-EPI, and if you're really stuck in the AKI, go for cystatin C GFR. It's a very good marker for endogenous, and I think you should keep that in mind. And what biomarker do you consider better for AKI in the kids? I showed you in the slide. The sensitivity, specificity is very well there. And could you please share me a normogram of GFR under 2 years, how to calculate GFR, how to adjust drug, any chart to use? You're asking a lot for a half an hour presentation. I don't have that normogram. I wish I could discover that and give it to you, but I'll be happy to share the formula if you want to. And does it make any difference in clinical outcome, which is, I think I answered all. Anything I left?
No, Doc.
Okay.
All answered.
Any other questions? Any questions from Dr. Jamila Curry, Dr. Khalid Alhasan?
Thank you very much.
Thank you very much.
Thank you very much, Rupish. It's a wonderful talk and very enlightening us in very extreme short time. You almost cover most of the thing in terms of the definition of AKI, staging, classification of AKI, staging of the AKI, etiology, management, and as usual, which we talk renal replacement or supportive therapy, and the $1,000 or $1 million question, timing of initiation and liberations of the CRRT. In addition, also the dosing of the CRRT of different types and etiology of the AKI. So great thanks, Rupish. It's really wonderful talk and state of art and very terrific actually in very short time. So really highly appreciating. So the other thing, I'm so happy that from the attendance from different parts of the world, when I look the attendees now almost concurrent attendees above 250 with different parts of the world. Hopefully more and more colleagues, they know about our webinars that is continued. And as been mentioned by Professor Amr and our colleague, they give introduction about the fellowship. Still there is another 24 to 48 hours to register. So I will encourage all colleagues to register. It is very easy access from your home or your office. Just log in and take the talk from state-of-art speakers and state-of-art members and staff for the fellowship lectures. So catch up the times and try to register. You are most welcome. Once again, thanks, Rupish. Thank Sultana for wonderful moderating. Thank everyone. See you next time.
Any last word from Dr. Jamila Curry? She's here. She's a very senior nephrologist. And
Thank
this time I
you very
missed
much.
in-person meeting though.
Thank you very much.
Riyadh
You
is still
covered
on
all
my
the points.
bucket list.
Thank you very much. You covered everything. Thank you very much. We
Thank you,
enjoyed
Dr.
your talk
Craig.
very
Thanks a
much.
lot.
Thank you.
Thank
Just
you.
maybe
Thanks a lot.
maybe small question for
Yes.
how long you follow children with acute kidney injury looking for long-term sequelae? Is 6 months follow-up is enough if everything is fine, blood pressure is normal, urine studies as normal, creatinine is normal?
Yes. Yeah, 6 months is my cutoff. So I call them like in 2 weeks post-discharge. Then I call them in 1 month and everything okay, we'll do it in 3 months. Everything else looks fine. I'll start weaning off. But you're right, 6 months is a cutoff. With no
We have enjoyed
albuminuria.
your talk very much. You covered everything. Thank you very
Thank you.
much.
Thank you very much.
Thanks a lot. Thank you. Bye-bye.
Thank you. Bye-bye.
Thanks. Bye.
Thank you, Prof. Amr.